It's pretty much what everyone has already talked about. There's not a whole lot new with it. So most of the contraindications were to avoid active shoulder flexion, abduction, or muscle contractions in the first 6 weeks. So no lifting, carrying, pulling, or driving. I added this at the end just today. The amount of time you're in a sling really varies based on what kind of surgery you had, what kind of tear you had, and your surgeon. There's 2 types of tear, a full thickness tear and a partial thickness tear. And so that leads to 3 different types of surgeries. But it seemed pretty standard, at least 2 to 6 weeks you're going to be in a sling. Some of them are going to prescribe an abduction pillow, some of them will not. You can take it off for showering and range of motion if it is under supervision. So, phase 1 is 0 to 4 to 6 weeks, and all you really can do is passive range of motion, under supervision, and within your pain limits. The only thing that I saw the only thing that's kind of different that hasn't been talked about so far would be putty squeezes, and that's just using the TheraPutty versus a ball, but they're the same thing. And that's just because you can put it in your hand without taking your sling off, and you just squeeze, and it just helps to keep some of the other muscles active. Sorry. The pendulums, back, forward, back, side to side. Modalities, you're just looking at ICE and IFC. And then the goals, mostly in this stage, minimize postoperative pain and inflammation, patient education for posture, joint stiffness, positioning, hygiene, etc. Phase 2 is 4 to 6 to 10 to 12 weeks. And you're doing active assisted, maybe moving into active towards the end of that. You're going to do pulley exercises in single plane, combined diagonal patterns. You can add in now shoulder internal rotation, extension beyond neutral, and horizontal adduction. And you can do wand exercises, which we've gone over all of those already. So the goal for this stage is to have resting pain controlled, establish your baseline humeral head control, and ensure adequate mobility specific to the glenohumeral joint. The other thing you can do is you can add in massage of the scar if the incision is fully healed.
Brooke, you didn't say there was any, like, when they do their wand exercises, do they have a restriction of where they can go to?
In phase 2, no.
I don't think
It's pain. It's whatever your pain.
Whatever the pain is.
And that's another thing that they want you to do it under supervision as well, to make sure that your pain is controlled. And then phase 3, 10 to 12 weeks to 16 to 18 weeks, you're getting into resistant exercise and some strengthening. Although, as you probably noticed with the shoulder, you're still not doing a whole lot. Strengthening is still mostly just gravity, very lightweight, and you almost aren't going past certain degrees. So they said you start with light isotonics, which is basically just light muscle contractions. So you're going to do side lying, external rotation. Now you can add a weight. You're going to progress to start with the 1 pound, where stage 2, you're just doing it on your own. The wall slides, overhead ball slides, roll up the wall. You can use a ball or a towel. This is where you can add in stretching, anterior, posterior, and internal rotation. So this is active range of motion as tolerated, and this is when you can start doing, like I said, you can add stretches. You can't do any stretching before, or you shouldn't.
that really is it. And so we've covered a lot of that stuff. Just so you guys, oh, go ahead.
Did you want to do this back part?
I'm sorry. I was eager.
So the home exercises, they don't want you to start until phase 2 because everything in phase 1 they want under supervision, because you really don't want to tear anything you just did in surgery. Oh, I forgot, with stage 1, when you're doing the squeezing, you can't do that if you had anything done to your bicep tendons. You can't do any of that stage 1. So I just did, forearm towel, up the wall, pendulums, wall climbs, this TheraBand 6 ways, self-stretching. A lot of the shoulder stuff is really easy to do at home. You don't really need a lot of other stuff. So, and then I just put that rehab and the immobilization depends on what surgery you had and what tear you had.
Good. Good. Just so you guys knew, in your book on page 580, is this the right one? There's a really good kind of summary of that. And she hit it, but like it's really a slow process with a rotator cuff. It moves and progresses a lot more slowly. And this is one of those ones that, like, if you were to look at it, they might actually into like 4 or 5 sections, really, because even by the 3rd section, you're barely starting to add in some light range, like
Active range of motion.
yeah, active range of motion and resisted, starting some resisted range of motion and stretching. If you notice right here, avoid vigorous stretching, the use of contract relax procedures or grade 3 joint mobilizations for at least 6 weeks and often up to 12 weeks post-operatively to give the repaired tendons time to heal. I'm right here, sorry. Right there. So, and she hit on that, like even stretching for 6 weeks, you're not, so really for the first 2 stages, for almost the first 6 weeks after, you're controlling pain, you're doing some like passive range of motion, pendulum type stuff, and that's and then you're right, kind of doing a little bit with range of motion with other joints and only strengthening with the hands. You would want to go ahead and do range of motion like with the neck and stuff, just to make sure that that's staying, that you don't get stiffness there too, but there's not a lot you can do with the shoulder after a rotator cuff repair. So that's why if we can prevent that way back on in Valerie's stage, man, it's way better off, because the potential for them to go from this to frozen shoulder is actually pretty high, because you just can't do a lot of moving with this one, and we're about to see with some other ones too. Total shoulders a mess. So, I guess Jacob, you're up. Is that right?
I almost feel like they were afraid to admit it was 6 or 12.
Because we didn't get, nobody had subacromial bursitis, did they? So just know with subacromial bursitis, it's just inflammation, and so you're treating it really much the same way you did any of this, and actually much the same way you would do the tendonitis that we're talking about. You're just kind of correcting posture, trying to get the inflammation down. Once it's down, you want to strengthen the whole shoulder.
Yeah, I don't think they ever want to admit
I
how.
was gonna be pretty short there. Valerie just basically did my presentation earlier.
They're very similar, impingement and tendonitis, but I just wanted you guys to see them because you're in the books, and I didn't want you guys to look at the book and go, I don't know what that is.
This is supraspinatus tendonitis.
Supraspinatus tendonitis.
And you had slap lesion?
So the main cause is the impingement of the supraspinatus tendon. Causes the inflammation, which is the tendonitis. Other causes I found that could just be trauma to the shoulder, poor posture, other muscle weakness and laxity, and just age in general. The patient will come to you with shoulder pain, have issues with doing overhead stuff, and pain level increases at night. I'm guessing because rolling around and laying on your shoulders, or however people lay.
A lot of it has to do with use too throughout the day. Like, because it's like inflammation, you sleep through the night, and in the morning, by that time the inflammation has started to go down, and then people start using that joint again, and so by the end of the night they're often in a lot of pain.
And then and then also going to the pain usually radiates from the lateral aspect of the arm, and it just stays on the lateral side all the way down to the hand. Kind of went over all the other stuff. Some of the tests that we've also talked about are the special tests, the Hawkins-Kennedy or anti-can tests, found one the NEAR test.
Oh, I don't know that.
The what?
A NEAR test, I didn't really,
I honestly don't know that one.
it says forcefully flex the shoulder with internally rotated arm, causes pain due to the cerebrospinal tendon impinged.
Is that kind of like
So it
Hawkins
would have been.
Kennedy?
It would have been. It's kind of
Yeah.
like Hawkins Kennedy.
Yeah. Your total recovery time with all the phases is about 6 to 9 months, 2 to 3 months for each phase. During the acute phase, the main goals are to relieve the pain, of course, inflammation, prevent muscular atrophy in the shoulder girdle, and to maintain the range of motion as much as possible. Modalities we'll be using is, of course, ultrasound, hot packs, also shockwave therapy and infrared radiation. I don't know how those play out.
Infrared we don't really use a whole lot anymore. That's just light, and it does get it kind of into laser almost. I honestly don't know what shockwave therapy is. I've never heard of it.
I didn't really look into it either.
So.
That feels good.
I'm guessing it's got to be something along the lines of ultrasound, though.
Yeah. Maybe it's just different wording.
It might be. It might actually be ultrasound, but I've never heard it called that. So I don't want to say it is that and then be wrong.
You want to do a lot of the passive range of motion, obviously the pendulum exercises, joint lobes like what we learned in 125. I don't really remember the directions to use from because we did it on opposite sides.
For
Do you guys
shoulder
remember
joint
that?
mobs?
Yeah, because he showed us one way of doing it from this side, and then he showed us from doing it from over the top, and there's different directions.
I don't know. I wasn't there for that class. I would hate to like interject and be wrong. I know that like if you look in your book, there is a section on joint mobs for the shoulder, but I don't know if it's even the same as you guys were taught. So I don't want to like.
Would
Make
there be like is it just kind of one of those things like it's up to you whenever you're out there, you kind of just do it yourself? Or?
Well, I would just ask your PT. Honestly, I was never once asked to do joint mobs the entire time.
I think the book just talks about the grades for
Right, and I know that we're not supposed to like, and it depends on state because in some states technically you're not supposed to do any joint mobilization. Other states you can do up to stage 3, right? I believe. I know you're not supposed to do the high velocity ones, but really you're just mostly doing joint distraction, and you can do that kind of in different positions. But the book does go over them if you want clarification.
Yeah, and then also we do isometric strengthening exercises, like what we were doing earlier. Then going to the recovery phase, the main goals are just to normalize the range of motion in the shoulder complex, achieve pain-free activities, improve neuromuscular control and muscular strength. We would be using all the same modalities for that phase also. And also the range of motion, we'll be doing more active assisted to the shoulder joint. A lot of stretching to the shoulder capsule, deltoid, lats, and the pec muscles. Some of the exercises that we'll be doing for the resistive stuff is just normal like shoulder shrugs. I mean, you can grab a weight, give it to them, have them sit down and just go like that, work with it. I found press ups or even pull downs, internal, external rotators, also with the weight or the airband. I found a video that she mainly used the airband, and she would like put it under the chair. Also, similar to the one that Caleb showed earlier, like that. That's like straight forward. I've seen that they put push-ups in there, but I thought that would be kind of extreme for that phase or advanced.
I don't know. Push-ups are pretty advanced, honestly. Like you would probably be stage 3 in my mind.
Then going to the maintenance phase, you'll want the full range of motion, getting them to do more advanced activities, a lot more dynamic resistance exercises, more PNF stuff, and then like you were also talking about earlier, just getting them, encouraging them to do normal activities, motions that they would do every day. And it's basically all that.
Good. So, supraspinatus tendonitis is really related to impingement syndrome. So, it's the treatment of it's going to be very, very similar. Strengthening the shoulder, strengthening the back, getting posture correct, because usually it's caused by impingement and it's causing that to inflame and get. It can be caused by injury and stuff though, so it might. But the process is still the same. It's that. At first, you're doing passive range of motion, and you're doing possibly isometric exercises, and you're trying to control pain. Once you're out of that first week or two, you might go into like non-thermal ultrasound to try and heal that the inflammation and try and reduce the inflammation. You might possibly start moving into heat for pain, but really that non-thermal ultrasound would really probably help. And then you're going into strengthening and getting them back on their way and doing functional activities. Good. All right. I think next is thoracic outlet syndrome.
TOS.
Hi guys. So mine, thoracic outlet syndrome, is not a surgery. You know, there's not phases to it, but there are different types. So we have okay. So there's three different types. Neurological, really it's just going to be like, all of these have pain and numbness going down, like the arm and whatnot, but hold on, go back up. Does everyone know what thoracic outlet syndrome is? Do you remember? Right, tightness of the scalene. It is actually figure 8.8 in module 8 of your notes, if you guys want a visual. So really all it is most of the exercises that you'll be doing is stretching for this. There's not a lot of, I don't know, like resistive range of motion or anything like that. But I'll get into like why you do certain exercises and why you won't. So a lot of these are going to have like pain and numbness going down the arm. You know, neurological is kind of classified like someone that has a lot of headaches. That would be kind of indicative of neurological. And then color changes in the hand. That's also indicative of that as well. Postural, bad posture, along with a lot of other conditions or things that we went over today. Just bad posture, you know, is that forward head? That's definitely a big one. And then vascular is really, it's very rare, but this one's really severe because, I mean, vascular, you think about it, what's a DVT? It's blocking blood from either going to the brain or from, you know, it's a blockage basically. That's kind of the same thing here. So if you have vascular, oh my gosh, excuse me, yeah, TOS. If you have vascular TOS, you're going to be pretty much occluding blood flow, you know, nerve, sensory, everything from the arm, and that can be really, you know, detrimental. You can't come back from that usually. So one of the big indications for vascular would be swelling in the arm. So you have like a lot of pitting edema or just edema in general, and then of course the pain and numbness and tingling and things like that too. So they're kind of all the same symptoms, but think about like our other neurological, I don't know, like think back to 130, like all of our nerve sensory conditions. So this, like, TOS is really hard to diagnose because it mimics symptoms of like rotator cuff injuries, cervical disc disorders, fibromyalgia, with all those kind of disorders, because it's almost like overactive nerve, but it's a pinching of the nerve. So, let's see. Okay, so really these two, I'm going to go over the exercises that we can work on for these two, but this one is more of a surgical intervention. I couldn't find a lot of information on it, like the phases and whatnot, but really the only thing I could find out was like within 3 months, the physician will decide plan of care, whether, like what type of exercises you can progress with that, but within 12 months you're back to full.
So does that mean for 3 months you're like immobilized?
Pretty much, like that's
For
kind of
vascular.
that's what it seemed like. There just wasn't
Honestly, I've
information.
never seen it or even like worked with it, so it's not one. And this is the problem. It's not like we can go through every possible condition that somebody could get.
Right.
But if we understand like the overall concept, you'll be good. So what would happen with this patient is, I guarantee you, the surgeon would send you with a sheet just like this, basically. They would send them with something like this so that you would know what you're supposed to be doing in the different phases. So don't worry about it too much.
And is that because it's rare
Yeah, it's just, and some of them are just so rare that you're just like,
that you'll get a plan of care with the patient?
yeah. Well, most of them actually, though, almost like, I would say 90% of people get some type of generalized plan of care, like the overall precautions and the different things they want you to do in different stages with most surgeries, just because different surgeons just are a little bit different and their phases are a little bit different. One will do like 1 to 4 weeks, one will do 1 to 5 weeks, and you just kind of have to go by them. So most of them will send one with them. If you have any questions, you can always call them and ask them, and they'll usually send one over for you.
Sorry, T.
Yeah, and really, honestly, with vascular, like, all I really found was if you're working with a patient that just, generalized POC or like generalized, if they have swelling in the extremity, they're showing signs of possible TOS, you probably want to direct them to a physician and stop treatment because you can definitely make that worse. So, going into that, I'll talk about some of the exercises and we all get to be helpers.
All right.
We all can do these. Okay, so we talked about the scaling stretch, right? We tuck the chin, so everyone can do it. So you tuck the chin, you laterally flex the neck, and then you turn to the opposite side, right? And you get that really good stretch, okay? So with this one, why wouldn't you want to do it with this?
It's neurological.
No, just with TOS in general.
Because you can include it more.
Right. Because when you twist, or when you rotate, you're basically occluding the brachial plexus on that side. And if they do have vascular, that can be very dangerous, just in general. But yeah, you're basically causing more harm than good. So for that, typically what I saw was really just looking forward, you lateral flexion of the neck, and then you can turn the chin up or down. So like you can go like this, but you have to have authorization from your physician or a POC to actually do that rotation of the chin. So another one, we've kind of already done a lot of these, but shoulder stretch. So I'm like, I'll just show you guys real quick. So you can stand in a doorway. It's in our notes too. But what I found was pretty cool. Since you're really wanting to just loosen all the muscles around the area, that includes the chest as well. So this one is going to be, you can start off lower, and you're kind of like this, and you just bring your, basically you're relaxing the rhomboids, but you're bringing your scapula together, you're retracting, and you move your arms up farther up the wall. Basically it like rearranges where you get the stretch from. So you can kind of just move your arm up the wall, and then you get more of a stretch in different places. So that really just stretches out the chest, and then, well, an anterior deltoid as well. And then this one, I mean, it's the scapula squeeze. It's really easy. I mean, I don't think you have to have your hands or your elbows bent at a 90. You can just have them sitting, and all you do is you literally just squeeze your scapulas together. That's it. You can hold, but the progressions of these are really just not really frequency, but like the amount. Like, so the amount of reps that you're doing these for. Yeah, so if they become too easy, you just increase the repetitions or find a little bit more, I don't know.
You could have them hold it too.
Yeah, you can kind of hold the stretch too. But there's a lot, like we've gone over a lot of the different types of stretches, but with TOS, I think one of the main things is to just remember no rotation, because just think about
It will temporarily tighten it. So especially early on in the treatment of it, you're basically just kind of bringing the head back first, because they're not just tight, they're tight.
Yeah.
Like, and so you wouldn't be able to get a full scalene stretch to start with, and you wouldn't want to, like you said, because it would, for a little while, it would pinch it even more. So you would really almost start with basically chin tucks and kind of come back. And then you might start adding some lateral stretching. And then as it gets better and the symptoms improve and you've done the chest opening and things like that, eventually you would move them to a full scalene stretch, but that takes a while to get there.
Yeah, like I was reading a couple months. I don't know. It just depends on the patient, kind of like, pain, revisions, and whatnot. So like what, and I do apologize, I jumped all around on my page, so that's why I didn't put it up there, because it's kind of confusing. But one thing that you want to do, like before treatment, or just, I don't know, maybe on a daily basis, would be like to warm up the muscles, and like literally warm them, like use a hot shower or heat pad on low for 10 to 15 minutes. Because it really just relaxes the muscle, just like thermotherapy would. Basically thermotherapy.
Would they do ultrasound in a clinical setting?
Well, that's what was
Not
interesting,
over
is the
the cervical
ultrasound
ganglia.
was
Right,
like an
that's what I was
actual
asking.
ultrasound.
Because you've got the cervical ganglia.
I didn't really read anything on that. But
Well,
it is
you just,
heat.
the cervical ganglia kind of run right here.
Yeah.
So scalenes, you can technically do ultrasound. You just have to be kind of smart. The only other thing is
It's
you're
the
actually
carotid.
getting close to that carotid. And so I don't know. I probably wouldn't, just because there's a lot there.
Well, the only thing I read on the ultrasound too was like actual like ultrasound, like imaging for vascular. Like, so they do MRIs and ultrasound
Right.
to really
I
find
was just
out if
thinking
that
to heat
is-
up the muscles. So
Yeah.
Since the heat pack doesn't go all the way down.
What about soft tissue massage? Is that a massage if you're in England?
I
Petrissage?
honestly, I don't know, but I can look that up because I didn't really see a whole lot on massage for this, but I would think there are some.
Well, it just depends on also like what's going on. If it's really inflamed, then you might have to wait a bit on that because you don't want to obviously make that worse. They probably would start with more stretching to start with, and then maybe move into some massage too, though, to kind of get that to loosen up. Eventually, they would for sure.
I was like, yeah, because I really in the acute setting, and like I really didn't see anything on massage. So, let's see. Also, something just because it's an impingement of brachial plexus, the scalenes are usually what is causing the impingement. Usually for inflammation. So, what could you do over the counter to help with inflammation?
NSAIDs.
Right. So, like Tylenol or stuff like that. So that's usually prescribed unless it's like pretty consistent or progressive, and
800
other
ibuprofen.
interventions kind of get put in place. But yeah, I think that's pretty much it. It was kind of
It's a fairly straightforward one. The thing that you have to know with it is it just depends on where they're at and how bad it is. So you just kind of think about if the scalene stretch is 3, you kind of just break that up and start with just one part of it and then move into that second part. And as time goes on and the symptoms start to relieve, then you want to increase. The other thing you can always say is if you're stretching them and you tell them, if I'm stretching you and your symptoms get worse, you've progressed too quickly. Okay, so like if you're in the middle of stretching them and they all of a sudden get tingling down their arm, you know you're stretching too much and it's starting to put pressure versus loosening up a little bit. And so it's just that they have become so very tight that it's a slow progression into those stretches.
And it's just like any other stretch. You want not a painful stretch, you want basically a pull. But if it is painful, you need to stop or redress the stretch. But I really didn't see anything on like.
It's a fairly, like I said, it's not an injury, it's not a phase one, it's not a surgical one for the most part.
Yeah, very rare.
It's mostly just slowly stretching. The only thing that I would really add in that is you do want to start strengthening like suboccipitals, and you want to start strengthening semispinalis capitis, and you want to start strengthening middle trapezius and the rhomboids to try and pull everything back up and into that right position again with thoracic outlet syndrome. So stretching for the front and gentle stretching and strengthening for the back. Okay? Good? All right. What? Total shoulder. We had total shoulder.
Yeah. Absolutely.
This one's a bit complicated, huh?
You guys covered everything. I feel like I'm like, wow.
That's
Matter
how
of fact,
mine was.
during lunch, I tried to like Google more complex
Exercises.
exercises, and I'm like,
The thing is it's weird. Once you guys really start watching, even if you start watching like online and Bob and Brad and Dr. Joe, there's only so many exercises most PTs really do. I mean, once you get into the high levels, there are stuff you can add, but especially for the first two phases,
It's the same.
it's pretty much the same. Like once you got those down, man, you're golden.
So your changes won't come until you're doing like the ADLs. Like, what do we need to
Right.
get you back doing? That's
And so
specific
that's
to you.
where it really, once it's like phase one is just like this funnel, right? It's really, really tight. And then phase two, it starts to kind of open up and you got a little more freedom of stuff to do, but still pretty limited. Like you're looking at wand exercises, cane exercises, 6 ways, and all those different things. And once you've done those are just, that's it, you know. And then all of a sudden at stage 3 or 4, depending on what you're treating, then it's like you can almost do anything. And so you really want to not curtail, that's the wrong word,
Tailor.
but tailor it to the person and their individual lifestyle and what's going on with them. Okay, sorry.
okay, no problem. So a total shoulder, practically what that is getting the ball from the humerus. They're gonna cut that off and replace it with a metal piece, and then they'll get the glenoid fossa and they'll shave it down and put like a I don't want to say a socket, but like a plate. And so that just kind of helps. There's also something that I realized whenever I was looking at this. They have something called the reverse total shoulder. So what essentially happens is instead of the humerus being the ball, it becomes like the socket, and the glenoid fossa becomes the ball. So I thought that was pretty cool. So I was like, wow, who would have thought? So with this, there's a lot of limitations as we've kind of already gone over. At first, it was like, okay, well, you can't do anything in the first few weeks, but after kind of doing some research, it does say that you can move it slightly a little bit more of passive range of motion. You don't want to do active or active assist. So like some of the things that we've already covered, the first stages you would do range of motion, like Brent said, with like your cervical ganglia and stuff. So just kind of, but kind of doing some stretches for your head, because of course that shoulder's not moving. It's in a sling for about 3 to 4 weeks, depending on what the surgeon says. There's also, instead of doing the wand sitting, what I saw done is on one of the YouTubes was they actually placed the patient supine, and they have to have, when they're in supine, they have to have a pillow or a roll towel underneath the elbow to support it, so that way they don't go into extension or hyperextension. So what they'll do is they will put the pillow or the towel underneath them, and they will get the
So let's have somebody volunteer and she'll demonstrate.
another pillow, grab another pillow too. One under here.
Mine gets replaced on requesting my elbow shoulder. Yeah. Just be different.
Whatever everybody else does, I want it back.
Oh, the opposite. You're welcome.
On your back. So essentially they'll be in the sling, so of course his arm's going to be kind of raised up here. So what you want to do is just put a pillow underneath it to kind of just stabilize it. And then what you'll do is you will have the patient, you'll instruct them, okay, so what I'm going to have you do is hold on to this one, and it can be anything, like I wouldn't say they should do this at home quite yet. I think you can teach a family member or a caregiver, and you don't want them to go past the 30 degrees, so you really want to be careful. But what they can do is they can use their arm. So you'd say, okay, this is what I'm wanting you to do, and I only want you to push your arm to about that far. And do that a few times. I really want you to make sure that this shoulder stays kind of stable and just barely getting that rotation going in the elbow and in the shoulder, just a bit. And that's pretty much the only other thing that I saw that was different instead of actually doing it in the chair is that you can do it laying down with the pillow propped up. I'm trying to think of what else. We've already covered a lot of the other things. Gosh. Why did you take so much of my stuff, guys?
No, that's good. So just the key things to know is just those range of motion. Like you can go passive range of motion to 90 degrees, right? And then passive external rotation to 30 degrees. Abduction only to 20 degrees. Internal rotation.
Well, that's saying like, okay, so like if you're laying down and you have your sling on, so internal rotation, that's what it was saying, and that's why I was like, I'm thinking that's right. So like when you're doing, because you don't want to do it,
Right.
You want to have it kind of a little bit abducted a little bit
Right.
to get
Okay.
that. So that's what it says, like
Oh, I see.
external
what you're
rotation with 30 degrees of abduction. That's what it, I was like,
this is one of the ones I went a little more in depth.
yeah, because I'm like, wait a minute. Because I'm like, there's like 3 different things. I said 3 different things. So I'm like, okay. But essentially, I'm like, I think it would be good to kind of get it a little bit moving a little bit more. Also, you can do isometric. So if they're like right here, maybe you just tell them, okay, so I don't want you to move too much of that shoulder, and I want you to just kind of put pressure on the elbow and just say, okay, just lightly push to wherever you can handle. Just kind of getting him to kind of start getting that muscle activated a little bit. Also, we can do the pendulum like we've already talked about. Also, you can do, of course, the gripping. You can do pull exercises, but they said most likely you don't want to do that until the 2nd week of the surgery. So I guess it really just depends on the surgeon, like we've already talked about. Let's see here. Phase 2 is practically continuing what we did and try to go from passive to active assist range of motion. So you can use light weights, a little bit like light TheraBands, and you can do kind of like what we've already done with, in the door, and you're getting the TheraBand and you're just kind of lightly. You can also do the walls to where you're putting that isometric and you're pushing that weight into the wall. Of course, heat and chiro, depending on how they handle. Also, at this point, you should probably start removing the sling, and they should only start trying to use it during sleeping. So that way they'll probably start to use it a little bit more. You still want to kind of be careful with that. Let's see. Scapular strengthening, already gone over. Begin assisted in horizontal adduction. I've already done most of the. Trying to think of anything else that I saw online that I can think of. The one thing, another thing I saw that instead of using like how Brent did over here with me as the patient, instead of pushing your hand, so like for home exercises, if they didn't want to do that, you can also tell your patient, okay, so you could use a chair instead. So you would just be like, I don't want you to put your weight into that shoulder. It's just there to kind of stabilize, so you'll have your shoulder here and just kind of walk back. That's another.
It's just a way to get range of motion in that joint without actually flexing the muscles. You're moving the body, so it's almost like a twist on the pendulum exercises where you're getting a little bit more flexion. The point is you just don't want them to go to the point of pain, and it shouldn't be a stretch at all yet because the capsule's not tightened up and ready for real stretch. But you can start, and they just call those walkaways. There's actually another name for them, like, I don't know, the name of the guy who invented them, but
Couldn't you also do like have at their table they could just have like a towel or something and then just putting
slides,
as
yeah.
far as they could
You
go?
just have to be careful with that because it's really easy with a towel and gravity to kind of get into more of a stretch. Does that make sense?
Yeah.
And so you have to kind of really watch that. That's why it's funny, back in phase 1, some people will call pulleys and wands passive range of motion. Other people will say it's active. So honestly, that's just one you have to kind of talk to your PT about. We got to where the lady that I work with, she was just like, I don't want you to do those because they're firing their muscles some to do it. And so we just don't want them to do that at all. And so really we kind of stuck the pendulum and a little bit of walkaways.
So is this like the other shoulder ones where you can't do any stretching until phase 3?
Yeah, and it's kind of weird because like some of the things that was in like both of our books are kind of different than that website, the paper that you sent us. So it's kind of different because that's where it says that it's okay to kind of do the pulleys at the second week. So I'm like,
And so
different.
that's the other thing is it will depend on it'll depend on where they have the surgery and who the surgeon was and things like that. So you just kind of play it by ear and play it safe. There's not, unfortunately, just like a universal protocol for these. And so the only reason I still want you guys to do it because I want you to know what the surgeries are, and I want you to understand that no matter what those phases are, there will be phases, and they will start with very, very light exercise or no exercise and move slowly up and progress, no matter what it is, pretty much, except for the few of them that aren't surgeries or injuries that we've talked about.
And the thing with the total shoulder too is you got to kind of think like with total shoulder, sometimes you can have to where the rotator cuff is intact. Sometimes it's not intact, so that also kind of plays a part into
Right.
your actual care as well. So like I feel like whenever I was looking at the reverse shoulder, like I told you guys, where they switched it around, that recovery time was more invasive, I believe, than an actual just regular total shoulder because it's dealing with more, it's way more invasive than just a total shoulder.
And like this, and even what the book says is way sped up from what it was when I was in class here, and the few that I've treated. You don't see tons of total shoulders, not like total hips and total knees, man. You see those all the time. They try and stay away from them just because it really is a long recovery process, and this is sped up from what it used to be. Because like it used to be basically for the first 2 weeks you weren't doing anything, not pendulums, not anything. And so you might still see some surgeons that use that older method, but this has progressed a little bit faster. But man, it's a really slow process with total shoulders, especially. It's a lot like rotator cuff. It just takes a long time. Good.
That's really about it.
Is that it?
No, like there's a few things back there, but also I was just thinking like for stretches, like once they're, like I said, whenever you could do hold relax, so like maybe even while they're sitting up and they're in the sling, you could kind of maybe just kind of like how we did the other day with Charisse, where she was like, okay, because that would help with the scapula, right?
Right.
So you could kind of be like, okay, push, like, but they're not really moving. They're kind of just, so I thought isometrics of the scapula was something that you can do. There's, of course, the cervical stretches. There's a lot of different things that you can do. And once they're actually functioning, you can also do the alternating. So whenever you're pushing and pulling on one and the other, trying to get that more stabilized. And then, like I said, for home stretches, you guys practically hit them all. There's just other things that you can think of. Like, I mean, if they didn't want to do it on that, they can use a chair. Also, you could also use a table and do it as well. Yeah.
Good. Overall, like, yeah, I knew we would cover a lot of it. Oh, wait. All right. So let's see what's next. Where are we at time-wise?
52.
Oh, man. We're basically there. I just wanted to see what was next.
What is next?
Oh, we can do. Who's got lateral epicondylitis? We'll do it just super fast. There you go. We'll do it super fast. It's not super complex.
Alright, so for the contraindications, I didn't really find much, just like active range of motion and active assisted range of motion, and no stretching when you're in the acute phase. So for the phase 1, so you want to increase flexibility, decrease inflammation and pain, and promote tissue healing. And you could start off with a nice massage and use a wrist immobilization, splint, and elbow band. You want to do a manual massage for like about 5 minutes before you do any stretch. You just want to do a manual muscle massage, and you want to use moist heat for about 10 minutes, and about twice a day for that. And you want to teach the patient to live with the palm up instead of the palm down. And just for general conditioning, you could use a treadmill about 2 to 3 times a week, just so they don't lose their conditioning. And just go to progressive strengthening exercises for shoulder and trunk muscles, because you don't want to lose those, of course. And for phase 2, it's to improve flexibility, increase muscular strength, and increase functional activities. And you use heating again, about 10-minute sessions before beginning of any active stretching. And each active stretching is held for about counts of 15 for about 30 seconds. And you want to start with like just extending out your elbow and just do flexion and extension. And for improved muscular, phase 3, I'm sorry, is to improve muscular strength, and you wanted to, you want to apply moist heat again before any stretch or any activity, and you want to perform active stretching exercises and progressive straightening. You want to begin with the number 1 weight and do it about 25 reps every other day. And you can do do the counterforce band in place. And you could do forearm supination, pronation with the weight. You could do wrist flexion and extension with the weight also. And you could do the ball squeeze and the finger stretch with elastic band. And during 6 to 9 weeks, and you can start playing sports again, just at 1 hour a day though. And during the 9 to 12 weeks, you may return to the sports without any restrictions. So for the stretching, that might be required. You could have the elbow straight and then just make a fist and just do the flexion and extension again. And home exercise program, you could have the practically, I think they're the same. Like, you could get a hammer also and do it with the hammer handle and just go pronation and supination. And that's about it.
Honestly, that really is
Yeah.
covered them pretty good. So, kind of gather around just for a second. So, honestly, any type of itis is just inflammation. So it's not necessarily like anything that's surgical. So you guys know the phases of that, right? The first phase, you're letting it heal. So you're not doing any active range of motion, just like she talked about. So you're going to be doing ice to that, and you might start doing, in fact, I guarantee you would want to start doing some non-thermal ultrasound to kind of speed the healing in that area. And then you're going to move from there. You can also do still passive range of motion, that you would do that just to kind of maintain. You're going to strengthen everything around it in that first phase. And then you're going to also make sure that you can do some isometrics as well. Keep those muscle firing. It doesn't take very long depending on how bad it is, but after that first week or two, you can move them into that second phase. Then you're just moving into more active range of motion, possibly maybe just some light kind of manual stretching, depending on how they're feeling. And then you're moving into more of the exercises. What she was talking about, and there are ways to do it. For supination and pronation, obviously you can start with this, right? If you want to advance it and make it a little bit harder, have them hold here. And when she was talking about the hammer, a hammer is really good because it's got the weight up here. And so if you go here and then hold it for a second, it's going to add a natural stretch to it. And then you can go back and it's going to add a natural stretch to it. So once you get them past that, you know, obviously passive range of motion, isometrics, ice, then you're moving them into more heat and active assistive and active range of motion. So you'd have them start doing just hanging over the edge, go against gravity, go up, go down, and then ulnar and radial deviation as well. And so any of the wrist activities, you want to do them all. And then moving into that final phase, once they have no pain, you want to start stretching. Okay, so you would want to stretch both the flexors and the extensors to kind of get it going. Just to kind of know that. So here and here, those stretches, and that's really how you do it. You can either have them with their hand down, depending, or you can have their hand up and go this way, and vice versa. Okay. And then obviously moving into TheraBand exercises. What she was talking about was wrapping it around. You can wrap a band around their hand and have them do this as well. Even just get a rubber band and put it over their hand and put it there. Squeeze exercises, squeezing with those. This one's a really cool one because you can have them pull and it just adds that stretch to it. A hammer is one they can do fairly well at home. And then just, they want to just keep it strong and keep it active. And usually they go out and they're doing too much without any stretch or any strengthening. Is when they usually just get back over. Any questions over there? All right, so we don't have a whole lot more actually to go, do we? I think we've only got 3 or 4 more presentations left, and then we should be ready next class to I'll just pick some of these and we'll put it up on the board for you guys to see, and we'll pair up and we'll practice doing it. And so we'll have all the stuff out and we'll just practice actually like, this is what this patient is, this patient has this. I want you to go through the stages and I want you to practice these exercises so you kind of get a feel for them. And the other thing I want you to think about as you're doing them is, how would I progress this? How would I regress this? So that you're good and ready for practical. Okay? Any questions?
You said you're gonna make copies of those papers and give
I
us.
am. So that's the other thing. I know some of you didn't do your papers. That's okay. Have it ready by Tuesday, and then the ones that some of you like Taylor's like, mine's kind of disorganized. So if you want another copy of the paper and then kind of like regroup it a little bit, no problem.
I could just rewrite it.
Right, that's what I'm saying. I can get you just like a blank sheet, or if you want to type it up, like I know Eric, like I'm not much of a writer. If depending on where he's at in his cycle of joke from earlier. So anyways, if you want to type it, that's all fine with me. If you have it and yours was good and you're happy with it, I'm happy to print it off and just keep it like that. Like I printed off mine, it was good enough. Because I just want you guys to have it and have the overall general ideas of each, and I want you guys to start thinking about how would I treat these people in these situations, and think about the exercises and know how to do all of them. And know how to, not just know how to do them, but know how to tell somebody else how to do them. Right? Alright. So yes, to answer, I can't remember who asked it, but I'm gonna make copies of the ones that I have. If you don't have one, that's okay, just get one. If you need a new copy of the sheet, just let me know, I can make you one. And have that ready for us Tuesday so that we all will have that information for you guys to use